thank you for coming. Stephanie, you can come in anytime. Our topic is Helpful Cocktails, a mixology of psychotropic meds and addiction medicine. As you can tell from our names, we're either brother and sister or spouses.
Or recently divorced, and I didn't change my name yet. It depends on how today goes. No, just kidding.
This isn't starting off well. No. So, which takes us to our first slide. I don't know if anybody can read that, but why are the two of us speaking the
It says,
caption?
have you considered substance abuse?
So, in fact, this is pretty close to our discussions in the evening, who took out the garbage, what our son's grades are, that kind of stuff. But we do spend an inordinate time talking about substance abuse treatment and the issues that involve it. And I think just sort of non-CME disclosure, how did we come to both treating substance abuse and working with systems that do, are in somewhat different ways. Early on in my training, I had general psychiatric training and focused in emergency psychiatry and was involved in psychiatric emergency services. And as my colleague Rick knows, that one of the most difficult things about running an efficient and effective psychiatric emergency room is to somehow figure out what to do with all these people with substance abuse that come in that you have to deal with and send elsewhere instead of dealing with mental health. That was kind of state of the art some 20 years ago. Identify who has substance abuse and remind them that they came into the wrong door and they need to go somewhere else first and have their psychiatric emergency later. Clearly, research subsequently has shown this was not the best tack. And we have, whether or not we signed up for this or not, recognized in mental health that we have to understand substance abuse, we have to treat substance abuse, or at least treat mental health issues in a way that doesn't run counter or interfere with treatment for substance abuse. That hopefully is together, and that is both clinical but also systems.
So the way I came to it was I finished my psychiatric residency training at Cedars in 1990 and went straight over to the dismay of my colleagues to Kaiser. And spent the first 10 years in the department.
I'd point out your colleagues at Cedars are no longer there after their psych unit closed.
I'm alive and well, but and very happy. So I was, for the first 10 years in the Department of Psychiatry, doing outpatient work and consults to the hospital, psychiatric consults to the hospital in the emergency room. But in 2000, the internist who was running the Department of Addiction Medicine at the medical center where I was retiring. And they decided that since it was becoming clearer and clearer that integrated care for patients with addictions and psychiatric illness was optimal rather than separating them, that perhaps I, as a psychiatrist, should move over to the Department of Addiction Medicine and create a co-occurring disorders care pathway. So that's how I came into it, and have really enjoyed it actually, and found it very rewarding.
So, really, what do we talk about when we talk about substance abuse? Usually, while we both have clinical administrative duties, Stephanie is more the clinician, which is a high compliment. I unfortunately don't have that distinction right now, but when we kind of mix about different issues with particular individuals and cases, it usually goes along the line of something like this. Usually Stephanie is talking about a particular clinical case, and these are often patients with mental disorders and substance use disorders, and often with some remarkable psychopharmacology. And Stephanie will sometimes turn and say, what the heck kind of systems do we have around here
That's a clean version of what I would say.
that allow this kind of thing. What are you doing? And on the other hand, I turn somewhat defensively, I admit, and say, what kind of clinicians do you have that prescribe this stuff? And goes downhill from there. The bottom line, and one of the themes for today when we talk about the mixology of this, and on a day where we have remarkable possibilities open to all of us that weren't all that clear yesterday, is how can we work together to ensure that co-occurring disorders, treatment for co-occurring disorders gets better and works well. And what we know, and I think Ron Mandersheed really talked about it this morning, is partly we as clinicians, but it's also we, and all of us are a little bit of each, as system designers and stakeholders that just have to get this right. So that's a bit of our theme today. We focus here on psychiatric medications because in some ways, all of the issues with psychiatric medications are sort of a toxic microcosm of the issues in treating mental illness and substance abuse together. They're in every area, but in psychopharmacology, they sometimes tend to be more fatal and faster. So if we can deal with the psychopharmacologic interactions in mental health and substance abuse, we'll not only save some lives and improve some outcomes, but we might also help lead the way to fuller integration of these systems overall. So, theme from 60,000 feet, mixology in a crummy bar somewhere. What would that look like? And you might say, just for argument's sake, I don't think we're in a crummy bar now. We were a while ago, but we've swept it up anyway and cleaned it a little bit, but we're not all the way there. What does it look like right now? We have different providers of substance abuse and mental health treatment. It's just a fact. We still have that, by and large, throughout the public system. Not only that, but the communication between mental health and substance abuse clinicians is difficult. There are just geographical reasons, there's cultural reasons, there's, well, at least in mental health, we change the dialect we speak every few years with a new DSM and entirely confuse people. And then probably underlying that, separate funding streams. When we try to integrate treatment with separate funding streams, everything that one group does, the other group doesn't pay for. And so we can become, at least in public systems, really strong advocates of the other side doing the work because they're really good and it's their funding stream. We have separate clinical records, we have incomplete insurance coverage, and our training for co-occurring is inadequate overall. What would it look like if we...
Should I do this one?
Yes. Stephanie goes
do a
to
little bit of talking?
Stephanie goes to classier places.
So how about if I do the Ritz? So the contrary, if you imagine what would be the optimal circumstances, in some places, some degree of each of these is in existence. So you would imagine that actually in the primary care setting, people screening for substance use disorders and mental illness actually know what they're doing and feel comfortable with it, both sides of that. And then that actually, when it is perceived that there are needs for those patients in those specialty care clinics, that they be available, either consultation or actual treatment, and that the clinical record be integrated, that it be readily available, everybody can see what everybody's writing, and actually still meet the regulatory requirements for confidentiality. That there, of course, be an integrated payer source so that people aren't cost shifting and doing that, and that the actual treatment itself be integrated.
Good.
Oh, you do it now, please.
Oh no, I said. So the broad outlines of what we'll cover today, we want to briefly, if Stephanie has her way about this, review cultural and clinical concerns about med use in substance abuse disorders. There's a little bit of history and baggage we all carry about the way we've managed this before, and not to be masochistic about it, but we can learn from history a little bit. Then we want to focus on treatment standards for using meds in substance abuse disorders. We'll even pick a particular contentious case that we have only slightly modified from the original and talk about how we would apply those standards. Not that we necessarily know, but within this room is one heck of a lot of expertise. So we can discuss it together and vote if there's strong disagreement up here about it. And finally, we want to have an opportunity together to speculate on what we can all do in this morning of systems change to help steer this. Where exactly do we want to go next? At a national and state level, I mean, we can grandiosely talk about it, but at a local level, practically everybody in this room, just looking around, has a big stake in it and also has some responsibilities for getting it right and working together. Many of us meet in many different rooms about this all the time, and now we have a really important direction to go. So,
Rod's going to do the history. He loves the history.
I'm going to do
Actually,
it.
it's a terrific framework and context.
I'm going to do it very briefly, however, I've been told. So, I wanted to start with the Babylonians, but that got nixed in the final slide cut last night. So it's a compromise. We go back, and it's appropriate today after the election, to the founding fathers of our country, one of them, oddly enough, being a psychiatrist, Benjamin Rush. Not only was he a psychiatrist, but he focused on co-occurring disorders. None of that quite made it into the Declaration of Independence, and we've been dealing with that today. But one of Dr. Rush's interests was the effect of alcohol on the body. Interestingly enough, aside from mental illnesses. And his famous paper, Inquiry into the Effects of Ardent Spirits being the good stuff from Scotland at that time, or the Bahamas, on the human mind and body, alcoholism as disease. This really started a whole period of inquiry in the 19th century where the whole idea of alcoholism as a moral issue, religious issue, social issue, at least within the so-called golden age of medicine at the time, it became firmly seen as a disease. Its first name in 1819 by Hoofland was dipsomania. The first person to use the word alcoholism was in 1849, Magnus Huss. When you start having diseases, you start thinking about treatments. And in the 20th century, treatment for disease, in large part, is biological. You might wonder why we waited so long for substance abuse. There were some early pioneers in using medication for substance abuse treatment. Sigmund Freud almost destroyed his career just as it got started by strongly advocating for cocaine as a maintenance treatment for opioid addiction. Not probably the smartest thing he ever did. And within a couple of years, there were various medical societies that thought maybe he shouldn't be publishing anymore. He switched fields slightly, and the rest is history. But the idea of treating substance abuse disorders continued. The first part of this century is more or less blank about that. Why is that? Because the rise of effective psychopharmacology really started in 1946. Anybody know what that was? Just out of curiosity. Everyone remembers Thorazine and Librium. Actually not. I'm sorry? lithium, 1848, CADE. I have my academician here to correct any of these. Actually, meprobamate, your grandfather's Valium, which was calming but unfortunately made you seize. And then the first antipsychotic. This is a great exam question for medical students because they always get it wrong. What was the first antipsychotic? Hey, everyone says Thorazine. No, it was reserpine, which made you less psychotic but really depressed. So that wasn't so cool either. Then there was lithium in 1949, rapidly the development of benzodiazepines in 1955. Well, it wasn't more than 2 years, and I couldn't find the ad, but Librium was being marketed as a great alternative to drink. So it started very quickly, and as new drugs came online in the middle part of the 20th century, we engaged in just an orgy of using these medications to treat substance abuse or mental health problems in people who use substance abuse. And there is a long list of famous people, probably starting with Marilyn Monroe only 6 years after benzos became available. Elvis Presley, Anna Nicole Smith, et cetera, all highlighting the kind of misadventures we can find with this. Along that way, there was kind of a hypothesis that all of us kind of think about and some of us keep to ourselves about what is our rationale, our real rationale for using psychotropic medications in people who are using substances and who may or may not have psychiatric diagnoses. And we talked about it behind closed doors and in the dark. For a couple of years, we called it, I think he's self-medicating. Interestingly, that wasn't formalized until the end of the century in 1997 with Kanzian, who formally wrote about the self-medication hypothesis, which we all sort of believe to some extent, which is that people who have mental illness and substance abuse, one of the prime causes for those two things coming together is that people with mental illness struggling to recover have their own homemade psychopharmacology, which are abused drugs, which they use as an attempt for treatment. Now, Kanzian actually didn't have the dominant model that we talk about. We think in his biochemical diathesis that the chemistry, we're fixing it with antipsychotic or other psychotropic medications. Kanzian actually he's still alive today, although very, very old. His hypothesis was actually that it was psychodynamic issues that were being treated. I mean, you got to read the article, go figure. But certain ego weaknesses and such could be counteracted with certain medications. But that quickly mutated, if it hadn't already, to fixing biological issues. There's one other larger expansion of that self-medication, the observation that there are cultural differences as well, population differences about substance abuse. I think probably the classic one was in the 1980s, before cocaine reached its final form, where you needed large denomination bills and mirrors to properly do it. And that was in the era of the 1980s, high-pressure Wall Street, and a whole theory came that this is a kind of self-medication to cope with this. You could stretch this to issues of crack in certain populations, large-scale alcohol abuse in other populations, and so this self-medication hypothesis took on social as well as biological and psychodynamic issues, and I promised that I wouldn't go any further with Stephanie on this. So,
thank you for that abbreviated version. Okay, so what we're going to do now is look at what reasons really exist for actually using psychotropic medications in addicted individuals, because you want to be careful. So the first one is that if it's pretty clear if you have a primary psychiatric illness, You want to treat that because you know that the results and the likelihood of success in treatment is going to be optimal or even better if you treat both conditions. The second one is that if you have the situation where you have psychiatric symptoms that are caused by the substance use that could conceivably interfere with the treatment and recovery, you certainly want to treat those, like psychosis with cocaine, etc. They like what I say. And the last is the little bit more controversial issue of using medications to actually treat the substance use disorder, such as anti-craving medications.
And of course, there's one more that actually did make it to this slide, but got cut out. We talked about funding streams and such. Another use of psychotropic medication in addicted individuals. If you're aware of funding streams, you know that the funding stream for treating substance abuse straight is tiny and inadequate compared to the funding stream for treating mental health. If someone has a mental health diagnosis as richly evidenced by their broad range of prescriptions, why then the substance abuse becomes a more minor issue that's just part of removing the barrier to mental health treatment. So the use of psychotropic meds can be an excellent way to access alternative funding streams. That may not be as clinically appropriate as the other.
That's why we took it off. Okay. So what, but on the reverse side,
But you
I
know
just want
who
to
you
get through
are
all the
out
slides, guys. Okay, so on the reverse side, why do we give them? On the reverse side, what are the risks of giving the medications under these conditions? And obviously, the risk of misuse in this population is greater. Secondly, that misuse could include diversion, criminal diversion, selling, etc. Thirdly, if we give medication, it could conceivably obscure the clinical picture, and then we don't know what's causing what. There are too many layers of possible etiologies. Fourth, we want to minimize the likelihood of having drug-drug interactions, medication-drug interactions, and we could do that by not giving medications, but sometimes we have to. However many that is, 5, this requires a little bit of explanation, but that if someone's in a 12-step recovery program, there's some controversy about taking medication and whether or not that interferes with the ability to actually fully benefit from the 12 steps. There are different ways of looking at that. And the last one, of course, is the risk of creating an addiction or a dependency just by giving the medication. I'm sure there might be others, but we haven't listed them. And isn't that nice that there's less noise now? Mm-hmm. Okay.
So,
this is like having voices, isn't it?
So, what we are now about to embark on is a series of intense discussions about a particular case. There are guideposts to treating. There are, and we want to call out a couple before we get into this. This is a relatively unexplored area. COD treatment as a topic has not been really dealt with specifically except in the last 10, 15 years. So probably a couple of references to call out for SAMHSA, Substance Abuse and Mental Health, how appropriate, put out a series of tips, treatment improvement protocols that are pretty good as far as quickly mapping the area of how do we treat. The two that are important, and you can find them anywhere, is tip 42, substance abuse treatment for persons with co-occurring disorders. It's very wordy, that's a warning, but buried in, it's a big topic, but buried in Appendix F is a nice treatment of using psychotropic medications in substance abuse, which swallowed an earlier tip called tip 9, which no longer exists, oddly. It goes from tip 8 to 10. And if you have to ask where tip 9 is, it's Appendix F. And then there's SAMHSA. I don't know if you're supposed to let anyone else know. And then there's SAMHSA tip 45, which is a thing on detox. The real standard for the field right now is the Principles of Addiction Medicine, the Bible for addiction medicine people. We swear by it. It can get you to pass your addiction medicine boards. Stephanie first demonstrated how to do this. This book is about, if we were sitting on one, you could actually see us.
Sitting on them. So, well, I just have to tell you a quick story, though, about this book because it has personal significance. First of all, Rod and I apparently study very differently for exams. My brain is very slow, and I need to have repeated exposures to topics in order to retain them.
Chapters 83 through 91.
Rod's brain, however, is like a steel trap, and he can hear it or see it once, and it's in there forever. So the way I study, can I tell this story?
I'm not sure.
So the first time I got certified was in 2000, and I started in 1999. Actually, it takes me a long time, so I studied for an entire year carrying this big book around, and eventually made it through the whole book. My son, actually, our son was very little at the time. He was like 3 or 4 or something like that, or 7. And when I finally took the exam, he said, "Mommy, don't forget your big book," because we were going to the park. I'm like, I don't need the damn book anymore. But anyways, on the other hand, and I passed. So on the other hand, Rod...
Well, so as an effort, I got to stop you. So as an effort to improve our relationship, I thought, since Stephanie was so involved in clinical medicine, I just came home every night and signed memos. Who knows what they said. But at any rate, I thought some closeness was in order. So I took Stephanie's book and I put it in my car.
Well, first of all, let me just remind you, I'm really sorry, but this is a really important point. ASAM was the only thing that I was certified in that Rod wasn't certified in, okay? He's certified in everything under the sun. It was the only thing I had that he didn't have. And then he announces he's going to take the exam, which really pissed me off.
But I wasn't going to give up, so I put the book in my car, and I drove it around for a year. The rest is history.
So he drove it around. He barely even opened it, but
I read SAMHSA tip 42, and that did it. So it's an important book, but don't get carried away. Tip 42 does it at a tiny fraction of the weight. But more importantly, this is really far afield.
Sorry.
One of the things we recognized, our community, in our public mental health community and our public substance abuse community, is that we were seeing the same population. There's a 60-70% overlap of people who have mental health and substance abuse problems. Our original plan, the way we dealt with these people 20 years ago, which is you're intoxicated, go to the ancestor of SAPC, Substance Abuse Prevention and Control, and they say, or 12-step says, you're a little unstable, get it together and come back for your 12 steps. We started treating each other's clients. We were amateurs in half of what we did, whichever area we were in. And so the two departments came together back in 2010, which seems like a long time ago now, but with Dr. Southard's leadership and with the whole national movement to integrating mental health and substance abuse, we recognized we needed to share standards and guidelines for how we were going to treat. Now, Department of Mental Health has endless guidelines called parameters. on our website. It's about 40-something now on various aspects of treatment that set standards for our department. This was a big departure from what we used to do and what our attorneys advised us, which is the best way to avoid liability exposure in mental health treatment is to not have standards. That way, if you're accused of being substandard, you can truthfully say you have no standards. So how could that possibly be? We're appalled that we could be accused of this. So about 15 years ago, we started to develop these standards. We have them now on our website, but to our attorney's delight, if you've ever gone to our website, you know that it is entirely encrypted. You can't find anything on it. It's 100% foolproof. The Chinese just give up. They know nothing about substance abuse treatment in co-occurring disorders. But we work together. What we do is we call groups of people together throughout the community, and we develop a parameter. It took us 6 months in partnership with Substance Abuse Prevention and Control, and we developed a parameter called the use of psychoactive medications in individuals with co-occurring substance abuse. It is encrypted but available on the DMH website. You can find it under Tools for Providers/Clinicians. Go down and you can find it. We will use this today as a way of, with the case, as a way of seeing, has this stood the test of time? What more do we need to do? What's the work ahead? So, that being said, we'll start with our case presentation. Feel free to ask questions, add detail if you know this person, whatever.
Okay, so we're gonna go through and read the case, and then as we go through the parameters, have a discussion perhaps about the case and how anything is applicable and what we could do to help the patient based on those parameters. Okay, so I'm going to read the case, and it's several pages long. Hang on to your seats. This is a 43-year-old female treated for co-occurring disorders at a well-known HMO on Sunset near Vermont. Transferred on a 5150 from a West Side General ER to a psychiatric urgent care center operated by a well-known public mental health department on Vermont, slightly south.
We believe this is fully de-identified and compliant with all HIPAA stuff.
Okay, so presenting problem. The patient was transported on a 5150 detention from her apartment by LAPD to an undesignated general emergency room after she called.
Does everybody know what undesignated means? Undesignated means it's not approved to hold people involuntarily and do psych treatment. It's just a general ER with people trying to deal with chaos.
After she called 911 stating that she, quote, overdosed on all her medications, quote, close quote, as a suicide attempt, but now was afraid to die. She refused to give further history and was transferred to county-run psychiatric urgent care clinic.
Technically county contracted, but.
Okay, now this is getting kind of dense, but hang in there. History of present illness. According to the patient, she has been in treatment in the addiction medicine clinic of a large HMO for some time. Diagnosed as quote-unquote bipolar.
But who isn't?
With drug abuse. She says that she was treated for 12 years in the HMO psychiatric clinic, but was transferred to addiction medicine 1 year ago because of episodic use of alcohol, benzodiazepines, and a little bit of social methamphetamine use. She says she was angry about this because she is forced to attend recovery groups in the clinic, and she didn't mention her HMO in the emergency room because she doesn't want to get transferred back there and get discharged. She notes that her psychiatrist in the addiction clinic treats her with divalproex and quetiapine. Continued. However, the psychiatrist has stopped her zolpidem, clonazepam, and topiramate, which, according to the patient, is because the psychiatrist isn't sure about her really being bipolar. As a result, the patient says she's been suffering from mood swings, most recently severe depression, and has been drinking a 750 milliliter bottle of red wine daily for 1 month.
It's a different bottle each day.
Borrowing lorazepam from a friend, that's true, it did sound kind of weird, borrowing lorazepam from a friend and using quote-unquote moderate amounts of illicit methamphetamine from a casual boyfriend to get up, function, and party a bit. She says that she wants her, quote, regular bipolar meds back, close quote, in order to control her mood swings and allow her to stop relying on drugs. She does note, however, that she can manage social alcohol and drug use and doesn't want to be sent back to rehab. Past psychiatric and substance use histories. The patient states that she has had 3 past psychiatric hospitalizations at ages 28, 35, and 39, with the diagnosis of bipolar disorder type 2, all occasioned by suicidal thoughts, with 1 attempt via overdose with alcohol and alprazolam. She's used alcohol, marijuana, and a variety of illicitly obtained prescription meds, excuse me, and in the past 5 years, occasional illicit methamphetamine. She has experimented with oxycodone, OxyContin, and ecstasy, but denies regular use. Past medical history is unremarkable. Social history, she works as a checker in a grocery store, has been suspended over missing shifts, and thinks she will lose her job. She has a boyfriend that she doesn't like, and sometimes, and sometimes goes out with a group of high school girlfriends. Her physical exam is unremarkable. Her labs are remarkable for mild, elevated liver function tests that are reflective of alcohol use. Her blood alcohol level is 0.06, and otherwise the labs are unremarkable. Lastly, her mental status exam. She's alert, fully oriented, she's angry, she has normal cognition, no psychotic features, has some vague suicidal ideation, but states she has no intent, quote, if I can see my old psychiatrist.
As opposed to her mean new one,
Her mean new one.
who's
and-
de-identified here.
And not have to do those stupid groups, close quote. All right, so hopefully that's generated some recognition and some thoughts, and we have a few questions.
So the question number 1 for us, since many of our treatment standards are based on diagnosis, is what does this person have? Can you guess what her what diagnosis she was given at the UCC, or diagnoses? Any suggestions from this?
Okay, we hear a mood disorder.
We have a
NOS.
mood disorder, NOS. Substance-induced mood disorders.
What?
Polysubstance dependence. Anything else? What? Alcohol dependence. Going.
Probably got a 296 by history and perhaps a mention of personality disorder depending on who's in the ED that year.
No kidding. All right, so we could straight axis 2, but we shouldn't have that much fun. So, staying on axis 1, I'm surprised. Think about your funding stream. No. Oh.
Bipolar 1, primary and secondary polysubstance.
Bipolar 1 primary, secondary polysubstance abuse. Okay, well anything missing there?
I see our diagnosticians are sitting up front.
Okay. All right. Well, fair enough, but remember those diagnoses. We'll come back. They are so early 21st century, but we'll get to that in a minute. Okay. If we treat her alcohol withdrawal, which she does have mild withdrawal, did have, I don't know how much it comes across
Let's just
there.
assume she has alcohol withdrawal.
She did. How shall we treat her before sending her back to her mean psychiatrist? Anticonvulsants.
We had an argument about that. It's funny you say that. That's the first thing said. Go ahead. Anyone else?
No.
No, I wanna move on.
Please expand. Please explain to my colleague why we would use anticonvulsants. Maybe you can do a better job. That working in a substance abuse program, treating withdrawal, it used to avoid issues of iatrogenic benzodiazepine abuse or misuse
She didn't
and
say
issues
that,
of safety.
actually. But she would have gotten to that.
Oh, I thought this was.
Yeah, no, that no one had seizures and things went well. So in the literature, the first-line treatment is benzodiazepines, however, it is frequently done to use anticonvulsants, but it varies.
By which side of the table you're
You
on?
sit on. Could you hear her in the back? It was a really nice overview of using one medication, the valproic acid, to cover your bases, given that we're not exactly sure what the diagnosis is. So we're covering the mood instability, we're covering the alcohol withdrawal, and right. And
So, right, and so the actual quote was that the case presentation itself is difficult to tell whether or not it's a primary substance abuse or a primary mental health. I just wonder if that's in contrast to real life or not. I think, so, which is a great segue to the last question before we start looking at the standards. In all of this, so it is a UCC at 23 hours. If that person doesn't go somewhere, we're in deep trouble. Oh, wait, the State Department of Mental Health no longer exists. Well, it doesn't matter, no. So we would have been in deep trouble when this case actually occurred. There was still a State Department of Mental Health, and we would need to, that person would need to leave by 24 hours. It's a urgent care center. If we don't hospitalize her, which would be a separate issue, what would you send her out on, if anything? Who would prescribe that in the first? No, I'm sorry.
No, that's really good.
Okay, so not Seroquel.
I like all those reasons.
Okay, so a prescription for no Seroquel. Anything else we talk about? If only Rick and I had thought about those prescriptions in the ER. No.
Got a hand back there.
Okay, well, there's a wide range of opinion about all of these issues. So, what can we look for in terms of standards? How about DSM-4? Afraid not.
That's really good.
It's currently in hospice care,
It's true.
but it will be gone. And as we are wont to do in this field, we like to change our terminology on a regular basis, sometimes in accordance with data, sometimes not. And so it might be useful to look at what we are facing in DSM 5.0, as it's being called. And 5.0 it's not fully set yet. It's coming out in a few months. We're still working around the edges. So see, all of this is currently in the draft. So it's open. But there are some critical changes in diagnosis, and you be the judge as to whether or not it will be helpful or more problematic in this case. So number one, substance abuse and substance dependence. Sorry, we're done with that. They no longer will exist as DSM diagnoses. They're gone. In fact, they're replaced now by substance use disorders, plural. There is also no longer a universal substance abuse or substance dependence. There's no longer a unified set for everything. So this is a major shift in how we look at this. They're substance-specific use disorders. So that's one big change. So we wouldn't have to decide if she has abuse or dependence. Now, that criteria set, since it's a little bit difficult because there's a different set for substance use disorder for each one, but there's one at the end, which the working title, I took this from the website, is unknown substance use disorder, which is pretty weird because what do you mean, unknown? You don't know if she's using it, you don't know which substance what. I think it's because everyone was sick of writing NOS and couldn't remember what it originally stood for. But it wasn't unknown. It actually was technical, level of diagnostic specificity, but unknown is weird, but that's what it's called now. So it's a maladaptive pattern of use, and everybody here is probably well aware of the original criteria sets for abuse and dependence. Suffice to say that with some exceptions, this is an amalgam of the two. So it's got all of our favorite stuff in there about monopolization of time, focus of attention, recurrent problems as a result, attempts to stop, impairment, physical damage, tolerance or withdrawal. These are all our favorite things, but there's one new one, long time in coming, which should help us a lot, especially in talking about in remission or not, which is craving. A strong desire or urge to use a specific substance is now part of the criteria set. You only need 2 of these 11 to have a substance use disorder. This is just an example of what it looks like. Alcohol use, this is from the alcohol section, under alcohol-related disorders. There's alcohol use disorder, which is more or less this criteria set customized for alcohol, and then alcohol intoxication, alcohol withdrawal, or alcohol-induced disorder not elsewhere classified. Well, what is classified? This is the new substance-induced disorder list, at least as of right now in the current draft.
Check it out.
Most of it are our old favorites, but does anybody see a new one here?
Yeah.
Look at that. There's bipolar. So there is now, at least if this makes it through the next few months, a substance-induced bipolar disorder. This is remarkable. This allows us, in this case, to say, bipolar disorder? Yeah, sure. Why not? What kind of bipolar disorder? It could be a bipolar disorder of the usual sort. We just call it bipolar disorder, or it could be a substance-induced bipolar disorder, but we wouldn't have to wrestle with the criteria set because they're the same. So people in addiction psychiatry, addiction medicine hasn't seen this stuff yet, but are pretty excited about this stuff, rightly or wrongly. We'll see if it survives into 5.1.
This is in distinction from a bipolar disorder, period, right? And this is caused by a substance, so you look
Yep.
like you have bipolar
Yep.
disorder, right?
Exactly. Okay, that brings us to our very own 3.6 parameters for the use of psychoactive medications in individuals with co-occurring substance abuse disorder. So, I'll spare you the introduction. It says you should know what you're doing, which takes a real stand in terms of, but know what you're doing in terms of treating comorbid medical conditions, risk-benefits ratios, and being able to treat substance use disorders. So, let's look at just some of the general parameters and how do they apply here. So, sweetie.
All right, so the first one, I clearly didn't write this because it would have been much more brief, but they are very inclusive and very descriptive.
A committee wrote
and
these.
right on point. So the first one essentially says that if you have a patient presenting with psychiatric symptoms that has comorbid substance abuse. Wait a second. This is why I have so much trouble with this. It's so wordy. Assessment of individuals with comorbid substance abuse should take into account the potential contribution of the substance-induced psychiatric disorders to presenting symptoms. So that means that if someone's abusing substances, you have to keep in mind that they could be causing the psychiatric symptoms. Is that correct?
It's not the way a committee would say it, but essentially,
Is
yes.
that what that means?
Right. So the first parameter, be wary of making psychiatric diagnoses, primary psychiatric diagnoses, in the face of substance abuse. And even if you should do that, in a couple of weeks, come back and revisit it. So any diagnosis in this case should be provisional. Absolutely.
So should we apply it to this case? Is that what?
I just did, I thought.
Okay. So just be careful. Don't jump to conclusions, basically. Okay. So if you're on psychiatric medications on
I
an
like this.
ongoing basis for treatment of a psychiatric disorder, they should be continued even if you're in the midst of coming off of abused substances. Unless, of course, there's some contraindication.
You might imagine this was a hard-fought thing in the committee and led to endless email about this. The standard we felt was that because all through our county, often in our divided network, if you're a substance abuser, no one should prescribe medication to you because something bad might happen. Well, unless you know what the bad is, it makes sense with many psychiatric medication regimens to continue them if you're not in some danger.
So that was the pitfall that we were falling into at Kaiser, at my medical center, when we decided to create that co-occurring disorders pathway, is that what was happening is that patients who were abusing medications or abusing drugs or alcohol and were being asked to stop or wanted to stop, but were also on psychiatric medications, the psychiatrists in the Department of Psychiatry were uncomfortable with the entire picture, sent them down to us, and were refusing to give the psychotropics at that time. But it was imperative that we have an evaluation of the actual condition and a decision whether or not to continue to treat that psychiatric disorder, despite the fact that they were going to be in withdrawal or in early recovery. And clearly, we supported that same second parameter wholeheartedly.
And then thirdly, and going right to the brilliant plan for detox that was proposed earlier with divalproex, when we are looking at pharmacologic treatment in people with an exacerbation of psych symptoms during a withdrawal or discontinuation of abused substances, explicitly consider, in DMH language, that means write it in the clinical record, so we know you explicitly considered it. Explicitly consider the adjustment of current medications as opposed to layering up new ones. That was a clear one. We should presuppose to continue current medications and document why we didn't.
And thus avoiding unnecessary polypharmacy.
Okay.
You do better at summarizing these things. Go ahead.
I can't read the small print. So for when we are considering prescribing additional medications during withdrawal, think about how those additional medications might be used in managing discontinuation symptoms and their interaction with abused substances or other things. Think before adding. We could have used a bigger font then. Psychoactive medication with a low potential for abuse should be preferentially described in individuals with comorbid use disorders. This isn't just during withdrawal. This is a basic principle. What is it about certain psychoactive medications, certain psychotropic medications, that make them abusable? Any theories? What ones should we avoid? So far, we have Seroquel. I don't know if that would be first on everyone's list. Yeah.
Wellbutrin, if Roderick gives a meth-like effect. Most guys with ADHD get addicted to Wellbutrin and get a chronic illness.
This is interesting. Seroquel and Wellbutrin. We're building our, remember, these parameters are 2 years old, and every 3 years we have to rewrite them. So thank you very much. Yes? Abilify. This is fascinating. So the first 3 drugs we thought about, quetiapine, bupropion, and Abilify. Anything else? Thank goodness we still have the benzos to fall back on. No.
Yes.
Okay. Someone's going with benzos.
Right, so that's really interesting. Those 3, the first 3 were not one.
Yeah.
I mean, I'm aware of the abuse potential, but I hadn't thought in those terms with this parameter. I had thought more in the lines of this one with the benzos, especially things that have a rapid onset of action and have a short half-life are very reinforcing.
So right. So our reinforcing medications are the ones we have to be concerned with. And as people point out these new ones, which is so fascinating because these are ones that show reinforcing behavior. And that might be a far more sophisticated way to look at it in the future. That's really exciting. You'll be on our next work group. Yes?
Yeah.
Interesting. That brings us to the next parameter statement. Only you said it a lot better. Medications for treatment of psychiatric disorders should not be withheld from individuals with substance abuse solely because they continue to use the substances. Rather, the medication treatment is the one that best manages the psychiatric disorder while minimizing potential interactions. This actually became a big issue in DMH a couple of years ago with our own homegrown, so to speak, industry here, the most rapidly growing industry, which is the medical marijuana shops. So if you read that rule, you know that it can be used for side effects from chemotherapy, certain other illnesses, and then anything the heck that someone says, you should use it for. Now, if you're a doc in a medical marijuana clinic, you don't want to go beyond your scope of practice, which is writing marijuana. And so you want to have specialty consultation. So what was happening at a number of our clinics, you can't make this stuff up. Some of our clinics are in the nicest parts of town. They sort of map very geographically with the marijuana dispensaries. People were coming in to our clinics helpfully stating that they needed a diagnosis of bipolar disorder. They really wanted it, despite the stigma, and would helpfully do the symptoms. And when our clinicians asked why, it was, oh, they just need could they write it down, bipolar, B-I-B-O-L-A-R, just sign here. Why do you need this? What, are you joining a coalition? What? No, I'm going across the street to the dispensary. I show them this so-called medical record. The dispensary can then say, with their Dr. Cush or whoever it is, says, well, by golly, I've had specialty consultation. This person desperately happens to need what my dispensary provides. So, but we should not withhold. And so, to digress, to bring it back, then some of our clinicians were saying, well, if you're going to do that and you're telling me, I'm not going to be writing you for other psychiatric medications. People complained. We actually had a statewide discussion about it and decided that policy should be, just because someone is using marijuana, medicinal or otherwise, cannot be seen solely as a contraindication to denying psychopharmacologic treatment.
So can I just add, for the person who asked the question, for me, additionally, other than the parameter, it would require an evaluation and a determination of, or at least a suspicion about what the original diagnosis was, and therefore why the medications were being given. And if you feel that those medications are necessary in treating symptoms that are disruptive to their ability to function and take advantage of the treatment that will help them stay sober, et cetera, then you would want to go ahead and give them. It's just the kind of the algorithm I use, but it's just a thought.
Yes. Really critical. Do people know how the Project 50, I don't know how many people are familiar, but how the 50 people in Project 50 were selected? Just so you know, a population is being talked about. We administered with multiple agencies a questionnaire specifically designed to identify the 50 people who filled out the questionnaire that are most likely to die within the next year. So these are very unstable people, and yet we still use this. The question is, so someone's been using crack or cocaine for 20 years, says they hears voices. They're down with the crack, but it's the voices that are a slight problem. Is that right? And they'd like that treated. What do you do? I think that a lot of the parameters about being diagnostically humble would be, and projecting that humility to the client is also not such a bad idea. And then I think when we talk more specifically about particular medications, that's where it would come. But would we treat that symptom if it were of distress to that individual? Probably, but quickly calibrating reassessment, and also, as was said earlier, this is not the be-all and end-all. There are other modalities, probably in this case far more important, to address other issues of substance abuse. Just briefly, a couple of other, want to finish. What about mixing? And this is terra incognita. Nobody knows. What about mixing psychiatric medications with anti-craving or other medication-assisted therapy? When we wrote this parameter, there was very little about this. So we just said the usual bureaucratic stuff about be very careful. Lab studies, ditto, we should use them appropriately, and that we should regularly query people about abstinence, about adherence to medication regimen, and very importantly, again in light of SBIRT and the other things we embark upon, motivational enhancement techniques should absolutely be employed to encourage the use of medication, not only to control psychiatric symptoms, but to move people on the road to recovery. Just a couple of caveats in order to get us out of here before dinner. We skipped some of the other exciting parts of this parameter, including the disclaimers. One of them is this is part of a much larger parameter on assessing substance abuse, which does call those out. The second thing that all our parameters say is if you're using this as a guideline to do treatment, if you're using this as your treatment cookbook, goodness help your clients. Parameters are set to, a parameter is a circle around it. If in DMH you operate within these parameters, enough said, you don't have to explain. If you operate outside them, you do. So this is not a substitute for knowing how to use all those tools, nor would we ever. There are other kinds of guidelines that are much more prescriptive than these. In DMH, we just draw lines around what is of particular interest to the department.
I think one of the largest challenges that I encountered when I moved from just straight psychiatry to the world of co-occurring disorders was the ability, my diagnostic acumen, and my ability to take a really good history, to separate out that psychiatric history from that addiction history, not to ask them as combined questions, but to hear the stories separately, and then to bring the timelines together to understand possible, what was pre-morbid and what wasn't, and what I should therefore treat. It's a really, really good point. I appreciate your making it.
Okay. So, this is just to illustrate, and we're not going to go deeply into this, because I actually think in terms of our discussion of antipsychotics, we've had the discussion here with the benefit of 2 more years of experience, and this stuff is now out of date on antipsychotic medications and SU. I think the interesting things we said way back then, 2.5 years ago, was that we should avoid sedating antipsychotics. We ought to be careful. We should consider depot more than we did, and that's becoming a bigger issue now. So we called out depot medications back then, and we also really were concerned back then about how people who might, in fact, as Ken talked about, have a maybe substance abuse is causing their psychosis. They stop using their substances because of good recovery treatment, and we continue on them on their antipsychotic until they die of metabolic syndrome because, well, they're not hearing voices. Well, see, that's why they're on an antipsychotic and never reevaluating. Antidepressants, there's a lot in here about cardiotoxicity and such that I think is, that people probably know and probably can't read from the slide. Issues of the interactions with liver and other metabolic pathways. I think that's fine. Mood stabilizers, a big issue back then with the bipolar. The critical things, at least for purposes of DMH and its allied organizations, divalproex was felt to be a heck of a lot safer than lithium in this population, and therefore, and also we at that time were really preoccupied with rapid cycling. It's funny how things change, and divalproex is felt to be better for that. I know there's been papers subsequently that suggest that that's not true. But then, of course, one has to worry about liver function with divalproex. And again, if you're prescribing mood stabilizers for manic symptoms during substance abuse, rethink that later. We spent a lot of time on anxiolytics. As you can imagine, this was probably the biggest set of disagreements and concerns. Roughly stated, the thrust of the guidelines is there are a lot of anxiolytics in this modern world of 2010 that don't end with azepine. And so stop it. And that tricyclics should be the medications of first choice for anxiety. What is?
You mean SSRIs, right?
It was a slip, yes. SSRIs.
That's when he practiced.
So very funny.
Sorry, that's when he was in the clinic. I'm sorry. Sorry.
It was downhill since nortriptyline. Anyway, I can still spell that. So yes, SSRIs are now the standard for anxiolysis, gabapentin and others, perhaps distant secondary, but benzos are a last resort. And there's a lot to recommend SSRIs, including some data on reduction of craving. And then if you're trying to treat people who want to sleep more, that is not a reason for Ambien. That was another, or benzodiazepine. It's not helpful. And there are several sedating non-tricyclic antidepressants, who knew, that are drugs of first choice. Trazodone, nifazodone, mirtazapine, Remeron, as everyone knows.
At low dose.
And then we tackled squarely the issues of benzodiazepines and said, come on, these things, anything prescribed during discontinuation of abuse substances, benzo should almost always be avoided. The almost was the negotiating factor. There should be overriding reasons for continuation of benzodiazepines past the discontinuation period, and they must be documented, overriding reasons. And because of their increased potential for abuse, they should not be used for the treatment of primary anxiety disorders or adjustment disorders in people with comorbid substance abuse. And there was more. We should avoid, as Stephanie mentioned earlier, reinforcing drugs are those with rapid onset and discontinuation, so long-acting benzos if you have to use them. 2010 was probably the last time someone wrote for Xanax, so it's probably not a good idea. We wanted to sound erudite, so we pointed out the obscure interaction between benzos and clozapine, which I make light of, but is a serious one. Agitation and delirium, if you are going to treat it with benzos, they should be parenteral and long-acting. Okay, so we treated this person successfully in the UCC. It's 23 hours and 59 minutes. Now she can go back out into her fully integrated mental health system where she'll get quick follow-up care from both her mean psychiatrist and her good psychiatrist. They'll work together closely with her primary care doc, and she will do well.
Yes.
Only at Kaiser, though. So the next steps are several. We just want to call them out. It's so important today, this morning, and also for this conference. We have to, in addition to developing clinician expertise and good studies and research, closer integration of health, mental health, and substance abuse would have saved this person. I'm not going to say what happened. Suffice to say, it would be good to have a seamless system. It would have helped to have decreased opportunities for cost shifting. And very importantly, and Ron Mandersheet called it out this morning, you would think this would be important, but we are aboriginally primitive in the healthcare system in doing monitoring. Not only do we not monitor, have an EHR, we can't even figure out yet precisely what we want to monitor. We do have some QA controls. 12-step, Stephanie and I have some perhaps slight difference of opinion, but it does provide a good counterweight to enthusiastic polypsychopharmacology. Quality assurance structures and parameters such as those we've talked about and other more naturally known ones. The development of intelligent EHR edits, which is a polite way of saying if you do e-prescribing, you can't prescribe that, or at least the medical record nags you. And our new chief pharmacist, Russell Kim, who suddenly sitting in front of me, reminds me that that will be a critical area ahead, to use intelligent editing within our information system to help. And then when all that fails, we have the law.
So I just want to comment, at Kaiser we have a massive electronic medical record throughout the state, and one of the things that we've done is worked very hard at those drop-down lists of medications and the order in which they are listed, Clearly, we have an issue about formulary versus non-formulary, but we also want to not list medications that are inappropriate or not list medications with inappropriate doses. And so you can drive care really just by the content and the order.
I see.
Yes.
Russell nodding enthusiastically.
Nodding his head.
The last thing, which is a call to local action, there are, as we develop standards, there are areas where we now desperately need them and don't yet have them. One of the big ones is the use of medication-assisted therapies. DMH actually is taking the steps, and Russell is, even as we speak, I'm surprised you're in the conference. I thought you were writing this memo this morning, Russell. But we are taking the responsibility to add to the DMH formulary medication-assisted therapy, and it should be. Yes, thank you. It should be available. It should be available within a few short weeks. It just takes us a while to get it written, and we will do this. We're doing it ahead of standards on how to do it. The way we develop work groups, so here's the ad. So how many, can I have a hands of people who will volunteer, please, to be on the work group to develop this parameter set? Don't worry. Well, thank you. Don't worry. We know it's really difficult, so the way we do it at DMH for all these parameters, you might wonder, who comes to DMH to do this for free? If you just ask people, they'll say they're really busy, but maybe one day they can come down if it works with their schedule. The best way, and we will do this, we will write the most miserable set of benighted parameters on how to do this anyone has ever seen. And we will pass them out to experts throughout the community and point out we are about to do this unless anybody has any small squabbles. And instantly our phones will ring with people demanding to be on work groups right now at midnight if necessary to stop this. And so we hope that people who are here with interest in this will consider we need to get these parameters out. We set this as a goal for the coming year. Thank you all so much.
Thank you very
Much
much.
appreciated.